Hello, this is Kim Jong-il. Today we'll cover our first lecture on removing occlusal force. In this lecture, we will discuss how to eliminate occlusal force in non-extraction cases, where it is difficult to attach the bracket to the correct position, which include cases of deep bite, anterior crowding, Class 2 malocclusion, Class 3 deep bite, and midline deviation. For Class 3 malocclusions, the posterior vertical dimension is sufficient. Therefore, it is not difficult to attach a device to the mandibular molar if it has sufficiently erupted. On the other hand, for Class 2 malocclusions, it is difficult to attach a device to the mandibular first and second molars because the posterior vertical dimension is insufficient. Attaching a device to the mandibular molar in such cases causes various problems. Attaching a device to the mandibular molar in such cases will make the bracket or tube of the mandible contact the teeth of the maxilla, causing various problems. Firstly, tooth mobility may occur. Secondly, the mandibular teeth incline further lingually because the teeth of the maxilla and the device at the mandible touch. Thirdly, the curve of Wilson will worsen. Fourthly, forward growth of the mandible is restricted. The solutions are as follows. First, perform strategic leveling in the early stages of treatment without attaching any devices. Second, use smaller brackets if possible. We can also use composite resin buildup, anterior bite plate, or posterior bite block. Simply put, we eliminate the occlusal force to attach the device to the appropriate place. To eliminate occlusal force, we may use blue resin or removable orthodontic appliances. Blue resin is mainly used on the maxillary first molar, mandibular first molar, or maxillary canine. The mentioned removable orthodontic appliances include anterior bite plate, posterior bite block PBBA, and twin block. Blue resin can be easily used on the mandibular and maxillary molars, premolars, and maxillary canines. It is difficult to attach a bracket to tooth 12 in the appropriate place for this patient. Therefore, I eliminate the occlusal force first with blue resin, then attach tooth 12 bracket in place and arranged into the arch. Let us quickly compare full bonding and strategic bonding. In strategic bonding, we open the space first and then attach the bracket at the time of teeth alignment and finally use blue resin. Therefore, the blue resin is only briefly used. On the other hand, in full bonding, because we attach all the devices in the beginning, the period of usage of blue resin will be extended. Long-term use of blue resin may have side effects, so strategic bonding is recommended. This patient displayed crowding at tooth 22. We first created space by using an open coil spring, and then used blue resin to eliminate the occlusal force when attaching the device to tooth 22. We removed blue resin after pulling tooth 22 forward. Blue resin is used on the maxillary first molar or the mandibular first molar, depending on the skeleton. In Class 3 malocclusion, it is better to be used on the mandibular first molar, which makes the mandible rotate posteriorly and downwardly. On the other hand, it is recommended to use it on the maxillary first molar for Class 1 or 2 malocclusion. I only use blue resin when it is only needed for a short period, 1 or 2 months. This is because long-term use of blue resin traumatizes and causes intrusion of the tooth. The first of the removable orthodontic devices is the anterior bite plate. When we use the anterior bite plate, the mandibular incisor contacts the maxillary resin plate, and the molar displays disocclusion. Therefore, the occlusal plane rotates clockwise as the mandibular molar becomes extruded and the mandibular incisor is intruded. The second of the removable orthodontic devices is the posterior bite block, which covers the occlusal surface of the posterior teeth. When using the posterior bite block, the mandibular molar is intruded and the mandibular incisor is extruded. The occlusal plane rotates counterclockwise. The third and last of the removable orthodontic devices is the twin block device. When we use the twin block device, the mandible moves anteriorly and the posterior vertical dimension increases. Let us summarize. When we use composite resin, the corresponding tooth becomes intruded. It should be used only for a short period of time, 1 to 2 months, and it is recommended to use when there is no significant change in the anteroposterior and vertical directions. When we use the anterior bite plate, the maxillary and mandibular molars become extruded, and the mandibular incisors become intruded and display labioversion. Therefore, the occlusal plane rotates clockwise. All uses of removable orthodontic devices increase the vertical dimension. In what cases should we use the anterior bite plate? It is recommended to use an anterior bite plate for deep bite cases. When using the posterior bite block, the mandibular molar becomes intruded and the mandibular incisors become extracted. The mandible rotates posteriorly and downwardly. Therefore, it is recommended to use it for non-extraction cases of Class 3 deep bite. When should we use twin block? With twin blocks, the mandible moves forward and the vertical dimension increases. It is recommended for Class 2 non-extraction cases. In summary, ABP or composite resin is used for Class 1. Twin block is used for Class 2 non-extraction cases, and PBBA is used for Class 3 deep bite non-extracted cases. Anterior bite plate can be used for cases of deep bite. Let's look at the case of this patient. There is mandibular anterior crowding, and the maxillary lateral incisor is slightly located towards the palate. It is difficult to attach the bracket in place on the mandibular anterior tooth. In order to attach the bracket to the mandibular anterior teeth in place, composite resin can be used to eliminate the occlusal force on the maxilla, and an expansion arch wire could be used later to increase the width between premolar teeth. Alternatively, expansion can be performed at the beginning of the treatment by using an anterior bite plate. This is ABP with SME. After installing the device, turn the screw twice a week. In the mandible, attach the bracket in place to relieve the crowding. After 2 months or so, we will have enough space in the mandible to arrange the crowded tooth 41. The maxilla can be also arranged by attaching brackets. We can observe tooth 14 and 24 expand. In the mandible, open coil springs are used at the first molar area to upright the mesially rotated second molar, while aligning the anterior region. Due to the lack of mandibular anterior arrangement, an open coil spring was used in 0.016 NET. Refer to the fixed appliance with expansion appliance part for details on attaching a fixed using the expansion appliance. The treatment is completed as the anterior part was arranged and the MIO was applied. Treatment was completed in 7 months. Strategic treatment can shorten treatment periods. Let's look at this patient, Class 2 non-extraction case. It is a deep bite, and we can see the maxillary lateral incisor is inward. It is difficult to properly attach a bracket on the maxillary lateral incisor and mandibular anterior teeth. We can also use blue resin to eliminate the occlusal force. However, it is recommended to use a twin block and attach a device when it is necessary to increase the vertical dimension in Class 2. To arrange anterior teeth, strategically attach the device by using a twin block and rotating the screw twice a week. For details, please refer to the part on fixed appliance with twin block appliance. I aligned the anterior teeth and finished with Mio. As for such cases of Class 2, where it is difficult to properly attach the bracket to the front teeth, the twin block can be used. Treatment took 11 months. Despite a bit of crowding, by increasing the vertical dimension, we can obtain positive results. Many people use rubber bands or mini screws to treat Class 2 malocclusion. If we use a twin block to move the posteriorly positioned mandible forward, we can significantly shorten the period of using Class 2 elastics. This patient has Class 3 deep bite. There is no crowding in the mandible. Mandibular anterior teeth are inclined lingually. There is crowding in the maxilla. Tooth 13 is impacted and 53 still remains. We can remove tooth 53 and pull the impacted canine. We may also eliminate the occlusal force through blue resin. However, I recommend the use of PBBA to eliminate occlusal force in cases of Class 3 deep bite. PBBA is the anterior teeth covered with a posterior bite block. First, we must move the impacted canine backwards. We can use lingual arch to do this. Then we arrange the anterior teeth simultaneously pulling the canines. If we make traction of canines after arranging anterior teeth, it takes longer and is inefficient. After the maxillary canine erupts, we put it back in place. It is recommended to use 0.016 SS with step base, arch wire, and overlay wire. Then we start the mandibular arrangement. When Mios are installed in the maxilla and mandible, and the occlusion is finally aligned, the treatment is over. The treatment process by using Mio is simple. We arrange the maxillary and mandibular anterior teeth and install Mio. The treatment is finally over. It took a long time to pull the impacted canine and to spread the maxillary crowding. It took 1 year and 10 months. We can see that the roots of tooth 12 and 13 are in good condition after debonding. In summary, for cases of Class 3 deep bite, in which the occlusal force must be eliminated to properly attach the bracket in the maxilla, use PBBA posterior bite block with anterior coverage in the lower arch. The use of PBBA is advantageous for Class 3 malocclusion treatment due to the arrangement in dentition and the posterior backward rotation of the mandible. What would happen if a case with tight occlusion is treated without extraction? Since it is difficult for the molars to move backwards, the incisors are likely to be labioversion. Labioversion on the incisor results in unaesthetic faces. Therefore, if the occlusion is tight, there is a high chance we should extract the premolar. We need to eliminate the occlusal force when we are unable to properly attach the bracket in place. Need to minimally use Class 2 elastics. Need to treat tight occlusion with non-extraction treatment. In such cases, it is recommended to eliminate the occlusal force and relocate the tooth. For cases of Class 3 deep bite, it is better to use PBBA. For cases of an antero-posteriorly large overjet and deep bite, it is recommended to eliminate the occlusal force with a twin block since the mandible must move forward. For cases of deep bite in the anterior teeth, it is recommended to eliminate the occlusal force by using an anterior bite plate. If one tooth is crowded since a bracket cannot be attached to the proper position, it is better to gain space, Apply blue resin for a month or two, and then rearrange the teeth. When we consider strategic leveling, we must initially consider the treatment goals Class 1 canine relationship and midline match. And for non-extraction cases with tight occlusion, in which the bracket cannot be properly attached in place in order to use less Class 2 rubber bands, consider removing the occlusal force. Thank you for watching.